Hello, everyone, and welcome to our September edition of our Q&A. And if you can tell by the graphic, this is an interesting day for Cindy and I, to say the least. And I apologize ahead of time for any glitches that we may have, but we will recover from them quickly. If you look at the graphic in the top right, it shows you where Cindy and I are currently located. And who would have thought that Cindy, being in the Western Atlanta area, was going to be at a higher risk than I would be in the Northeast Florida area. So I see some folks in the chat that are saying they're on the East Coast, just north of Darien, Georgia. I know exactly where you're at. And thank goodness we're going to definitely get some rain, and we'll get some wind, and we'll get some of the offshoots of Big Helene, but she is out there trying to get her name retired. For those of you that don't know and are not in Hurricane Alley here, if you cause a certain amount of damage, the name will never be used again. And Helene is vying for that right now, as she does nothing but strengthen in the hot water over the Gulf of Mexico. Little thoughts and positive thoughts for those that are in the path and those that have to deal with these kinds of things while you're providing home health. We actually did consider moving this Q&A, and then I thought, wait a minute, Cindy, are you there?
I'm here.
Home health, right?
Mm-hmm.
We all on this call do some form of home health, either a clinician or in management or in leadership. And what is more home health than providing a Q&A webinar to folks in the middle of this?
Yeah, I mean, we're better than the Postal Service in terms of a sector that is out there and
And welcome to our
webinar
today. So I'm not going to sing it right now, but we're calling today.
Can you hear me, Sherry? I can't hear you.
I think I muted myself.
Oh, there you are. Okay.
Please repeat what you said, because I think some folks were unmuted.
Well, I was just saying that, you know, we go through all kinds of weather in home care. And so we're going to soldier on with this and
Your agency and
I'm not happy with what's going on with the mute, so please, everybody, as I try and mute folks. So please, I will make that reminder again, mute your microphones, please. Thank you. Go ahead, Cindy, finish your thought.
Oh, no, I just think we're going to press on, and we got questions today. So why don't we go ahead and get started?
Let's get going. Okay, question number 1. When doing a discharge from an agency or discontinuing completing plan of care interventions, required documentation, does that have to go to the doctor to get signed, or to the mid-level provider to get signed?
I'm putting that one right back to you, former agency owner.
The requirement for this situation is that you notify the physician. It does not say that you have to have it returned signed. Obviously, that would tie it up into a nice bow, but you need to make sure that you have it very clearly delineated how you notified them, when you notified them, and that you have your HHABN in place with the patient as well. So that's a reminder to make sure that document's in place, so that nobody is surprised at the time you guys are going to discharge. And sending a copy of the HHABN would actually be a good idea, to send it to the physician so they have a couple days warning about when you're going to discharge. So that's my suggestion, but definitely make sure you document it well, that you sent that information and that you did notify the provider that they're going to be leaving home health services. Cindy, did you have anything you wanted to add?
I did not.
Okay. All right, and a reminder too to everyone, you absolutely can submit a question into the chat. We have 13 questions that were submitted by our users and our subscribers, so thank you so much for that. But a reminder, we're going to be putting these into the chat and providing the recording when we're finished, so you will have the opportunity to see this information again as needed. Okay, so question number 2. Starting the 25th of July, 2025, less than a year from now, all patients must have the OASIS completed. Does this mean that for payer patients, I don't know exactly what that, who strictly only receive visits for infusion and are not homebound. Is there a way to continue to do these visits without an OASIS since the IV payer does not require a OASIS?
Well, let me first interpret the question. The start date of mandatory submission for all patients is 7/1/25. So we can start voluntarily submitting on January 1 if we want to, but it will become mandatory. And it doesn't matter if it's an IV patient and they're not homebound. It doesn't matter if they're private pay. The interactions I've seen with CMS, anybody who's tried but what about so-and-so and gives an example, the response is consistently everybody. So the only exceptions that come into play here are the ones that are the true OASIS exceptions based on the patient's age. They're very narrow for ones that they don't apply. But for payer source perspective, it does not matter what it is. It doesn't matter if it's private pay. It will be mandatory on everybody.
That's pretty clear. And the hard part about that is that many of you have done this all along, but you've never submitted these to the to your state for the submission requirements. And starting on the 25th of July, Cindy, that means they also have to be submitted,
No,
correct?
it's July 1st of 25, not July 25th.
Oh, Lord mercy, I'm going to put that 7/1/25. Thank you. On 7/1/25, they have to be not just completed, but submitted, correct?
Correct.
Okay. So if you're not prepared for that, I think it's time now to start getting prepared for that. And especially who are the exceptions, Cindy? I should say that. Who are the exceptions under the OASIS guidance that don't ever need to have an OASIS?
It's I believe it's the prenatal patients. It is the anyone under 18. You got me with one OASIS thing I cannot think of at the top of my head, but it's clearly in the manual, and it's not about payer source anymore. So, like I said, any example I've seen someone try to post to CMS, well, what about this one? No, it's all payer. So, to your point of getting ready, although many of you may have been collecting it in order to keep a consistent process for clinicians, and some clinicians may go, what? We've been doing this for no reason prior to now? Okay, be prepared for some of those comments. But I also know that collecting it has sometimes met with not the same level of scrutiny as the Medicare charts. So yes, it's been collected and it's a stable process, but what about the QA of those? Because that grace period starting in January, when we pivot to mandatory in July, you know that initial data is going to be the baseline for future decision making. And there's really only one reason, one big reason to collect on all payers, and that is to expand quality metrics. So if we've kind of sort of cut a little corners or maybe didn't really pay that much attention when it was collected on non-Medicare payers, we're going to have to clamp down on that and make sure that the QA process is consistent across all. So when we start submitting that data, we know it's as accurate as possible.
So Cindy, someone had a great question. What about homemaking services only patients? Do they need the OASIS?
No, because that would not be considered skilled care.
Exactly. And I want to be really clear to everyone as we possibly clutch our pearls, which is what a lot of us in the South are doing right now. If you clutch your pearls and say, but what we have to do that, as an industry, we asked for this. I'm going to give a pause. What? We asked for what? Cindy, can you expand on that a little bit about how this came to be?
Well, asked might feel like a strong word to many of our participants today. They're like, I didn't send that in. Who did that? Who asked? And when can I go, hit them with something? But the reality is that our current quality data is on a portion of our patients that, quite frankly, for many of you is shrinking. Traditional, straightforward Medicare. So the involvement of Medicare Advantage and all of these other payers, to say that we're only going to look at this sliver of it, and we're going to use it to do your star ratings. We're going to use it for value-based purchasing. It's like I've heard from agencies that say, less than 10% of my volume really is that. So you could say that there's some positives potentially, because if there's any issues around payment adjustments based on that or quality measure things, it only hits 10% of your population. But in reality, it has been a push to say, if you're really going to look at our quality, you need to look at everybody. And also that gives them the ability to differentiate down the road of what are our outcomes look like for traditional Medicare compared to Medicare Advantage, compared to private pay. I mean, they'd be able to slice it and dice it in ways that they currently cannot. Because although the OASIS has that question of what is your payer source, they're only looking at the ones that are in that narrow window now.
Yeah, I would strongly discourage any type of feeling you might have. Okay, I'm trying to be very gentle with this statement, Cindy, and I'm going to just say it bluntly. We know that there's gaming that occurs with the OASIS to show better outcomes. Everybody on this call has seen it. Everybody on this call is aware of it. If we do the same thing with MA, if we do the same thing with Medicare Advantage, I just want you to think a minute about what CMS may get from that. If they see that the outcomes are wonderful in Medicare Advantage cases where we get limited care and we get limited number of times we can see them, everything is managed down to the bare bones, guess what's going to happen to Medicare? Cindy, what do you think about that?
Well, I think that's an interesting point. And we could go down quite a rabbit hole about what they potentially could do with that data. I think it just speaks to what the K&K mantra has been from day one, which is every time point, every question, every time, every payer, add that to it, needs to be following the guidance and accurately reporting. Even in situations where we don't like how it looks, it may be that because of a payer, we only were given 3 visits and the patient didn't improve in several key areas because they didn't get that much care. We're going to have to be willing to report that. Because to your point, Sherry, I think if we panic and it's like, oh, we got to make sure everybody looks better, it could blow back to say, well, if you can make people better in 3 visits, then why am I doing this episodic thing that's potentially longer than that? Why don't we just move everybody to these visit limitations? So it's important that even in those tough spots where you say, you know, this didn't get better, we weren't able to get this done, document about the limitation of the visits, but make sure that OASIS response is accurate.
Accuracy is everything. Okay, question number 3. There is still some confusion on if we take referral sources for OT only, can we complete a start of care with just OT, or does there need to be another skilled need service added?
Well, first of all, it does depend on payer source. So there are non-Medicare payers that are perfectly happy to just pay for the one service and have them do this. If we're talking about Medicare, Medicare does not still at this point recognize OT as being able to qualify them for home health services on their own. We know that once they're in with another service that can, typically nursing and PT, then they can continue on. If they need to recertify a person, they can do that standalone. So if the referral is a Medicare patient for OT only, we cannot do that because they're not considered a qualifying service. I think some of it, Sherry, with the confusion has been the discussion around who can admit them. So in a case where it's the therapy only, a term many of you know I absolutely loathe, but that if it's PT and OT, then we can have OT do that admission. That's not the same thing from a qualifying service standpoint.
And that's subject to change. I want to remind everybody that we're
Right.
still on the final rule, and the final rule could include that anyone can do the admission even if nursing is ordered, but I'm not sure that it can include OT can skill a patient, right, Cindy? Because that's a legislative thing. So can you just real briefly touch on why OT can't be a qualifying service at the start?
Well, the history lesson goes that it had to do with some of the punctuation issues, but what it comes down to is the AOTA has been challenging this for a very long time about it being a qualifying service in and of itself. And I really, no matter what explanation I've been given, it doesn't make any sense to me why it wouldn't be. But there have been concerns that mathematically they've looked at it and said, if we make another qualifying service, they have calculations that connect a qualifying service to an increased number in aid visits. And so they have said that making another qualifying service would increase costs in this sector because of the increased use of the aid, which I find absolutely ludicrous considering we're talking about OT. Why would that correlate to some growth thing in aid use. I don't know. But that issue is still, hotly contested. We are hoping that at a minimum, there was enough feedback in the proposed rule, at least to advance their RFI. Ideally, to just say, okay, we did get enough information and enough feedback this cycle, and potentially change that issue of nursing being the one who has to do the admin.
Yeah, and it's going to have to be a rider on a bill, everyone. So those of you that hate the pork that ends up on bills, there will not be, in my assessment, there will not be a standalone bill that goes before Congress that says to add OT to the qualifying skill, because that looks like a payment. That looks like an increased amount of dollars. It would
Right.
have to be an add-on to fix this error, and that's one of those things that you look at and you just shake your head and say, what happened? It's crazy, and can we ever see it gone? It's going to take some maneuvering and some manipulation for that to occur. And it's a shame, because Cindy and I are both extremely big OT proponents. We do not use OT enough in home health by a long shot. Patients need to get back to their personal care duties. They need to have as much optimization of their self-care. And OT is that. OT is it. They're more than that. But OT is the one that's going to get them being able to present themselves in a way that they want to. And that's so important to the quality of life as folks age in place. So I think it's a huge oversight that occurred. But Cindy, do you have anything else you want to add on that, except that we can stand on a corner with an OT sign?
No, I mean, it's just something we need to pay attention to. You're right, it ends up tacked onto other legislation, and every time it's done that, somehow the whole thing falls apart. So effort continues, but we want to make sure that we understand the difference from a qualifying service standpoint.
Mm-hmm. And if folks that don't know what AOTA is, it's the Association for Occupational, or the American Occupational Therapy Association. Let me get it right. If you go to AOTA.org, you can find out all you want to know about OT. It's a great website, and they're a great organization. So take a moment to do that if you haven't. And it can give you some really good insight into what OT does beyond just the ADLs in home health. Cindy, you ready for the next one?
Yep.
Okay. This is concerning a lapse in insurance. We recently had a patient who had coverage, but that coverage ended on 7/31/24. Due to late registration, it would not have been active again until 9/1/24. They were in the middle of a cert period and with a month without their coverage. He ended up doing PP for that month, but what would you recommend to be the best solution for this?
Well, I'm assuming PP is he private paid,
Yes.
but I'm looking for your insights on this one as well, Sherry, because I'm not sure what there is the best solution. The patient didn't have coverage. There wasn't anyone to bill. The patient did private pay that gap and then had insurance coverage after that. I'm not sure it could have been handled any other way.
No, and I'm going to recommend that folks that are in that situation, that you would discharge them at the end of that coverage and do a new start of care for the private pay episode and mark that as the payment, and be really clear in the chart why they were doing private pay for that period of time. At the end of the period, when they retain their insurance, another discharge from the private pay admission to the new insurance. Have I missed anything there, Cindy?
I don't think so, because the other issue is clarifying what they're paying.
Right.
In terms of the rate. But yeah, anytime you're getting into private pay, it really needs to be clear how you ended up there and the efforts that were taken to determine if there was any possible coverage available. But in this example, it doesn't appear that there was.
And as a reminder, in the current standing where we're at, you do not have to do OASIS moments for that private pay section at this moment. Now, starting 7/1/25, that's going to be a different thing. You're going to have to do the OASIS moments in that situation. But it's always a good plan to have some private pay paperwork available to be used in those situations, because one of the things that Medicare seriously will come knock on your door in 10 minutes is if you try to collect gap private pay from folks that are on a Part A service. So you want to, like I said, be crystal clear about what this situation was, because that's not what you're doing here. You're trying to maintain their coverage and they're willing to pay for it. Completely different thing.
Right.
than someone who's trying to collect the 20% or 10% or whatever's not covered by Medicare. So just be crystal clear on that. And again, until 7/1/25, there are no OASIS necessary for private pay. So that saves you a little bit of the work there in between in those time points. I'm going to go to our next slide, Cindy, because I want to give people the opportunity. You can use the camera on your phone. If you hit this and fill out our survey, you'll be getting a coupon code for 25% off of any one-time order of our online products. This is a huge coupon. The only problem is you have to do it by the 30th. So you have about 4 days left to do this survey to get the coupon. And we're doing this because we need to have some information from our followers to know what's best for us to prepare, to get you guys prepared and to stay in those, oops, I went to the next slide, sorry. To stay abreast of all the regulatory changes. Cindy, we ready to move on?
Yep.
Okay. Question number 5, patient admitted for femur fracture in GG0100. I want to play a noise. I wish I had a noisemaker. GG question. GG question alert. GG question alert. Code has started care upon functional status prior to the fracture. While on service, the patient experienced a CHF exacerbation and is rehospitalized. Here's the question. At resumption of care, do we code GG0100 based upon the status prior to the start of care? Or do we code GG0100 based on the status while on service prior to the CHF exacerbation? In other words, does the resumption of care initiate a new episode of care or only a new quality episode?
Okay, the issue is if we look at the question, GG0100 is talking about their prior level, and it specifically says prior to this illness, exacerbation, or injury. So in that example, you started out with the femur fracture. So what was their ability prior to that? They were rehospitalized for a CHF issue. So this is something different. And so we would be looking at the time period preceding this illness, exacerbation, or injury. So it's one of those where, yes, we know resumption resets things from a quality perspective. It's not a brand new episode. We didn't discharge and readmit them. But that question is very specific, and I made sure to look it up in case there was anything else that had changed recently about it. But it does specifically talk about prior to this illness, exacerbation, or injury.
And you guys, that's very important when you look at those little single words in between on some of those statuses on the OASIS manual. Be very clear on what they're saying, and if they're saying what one of the big ones is should versus shall, right? Cindy, there's some words. Can you real quickly talk about maybe some of those words that should stop you and make you know that you have to do something versus it's possibly recommended?
It's more of an issue with OASIS at times with examples. Sometimes they give some examples in it. Sometimes it's a very specific list. So it's one of those where we need to make sure we're literally reading what the question says. And if we have concerns about that, go to the official guidance and see what it has to say about it. But I think, kind of looking at this issue, yeah, the prior level would be prior to this illness, exacerbation, or injury.
Okay, well, thank you so much. Okay, so question number 6. We sometimes have to discharge a patient and readmit due to a change in insurance. This kind of goes off the one prior to this one. In this situation, is GG0100 prior function to be coded based upon the function prior to the original start of care, or based on the status at discharge just prior to the subsequent start of care for the insurance change? So what we're talking about here is that technical issue of when we have to do it when there's a payer change. Nothing has changed about the patient. So when you think about prior to this illness, exacerbation, or injury, this is going to be the same situation as it was when we started them, because it's prior to this issue that we're dealing with. So there wasn't an intervening event. There wasn't a hospitalization. Something didn't take the patient away from you. It's complying with the payer change that we have to do. So it would be continuation of what we had said was the prior level from the start of care. Okay, that's clear as mud, Cindy. But those are great questions, because the GGs are going to become more important beginning in the new year. And just as a reminder, they're going to be calculating the discharge on the GGs based on the data that they're gathering, and they're not going to be using, and Cindy, seems like a good spot for you to explain what is changing for how they're calculating that now with the functional items to what's going to happen in 2025. Do you mind doing that real fast?
Well, the bottom line is we're all going to see the removal of the goals column for the GG 130 and 170. And it's going to be a calculation, much like risk adjustment, looking at our responses in other areas to project what they believe to be the patient's ability at discharge. There's positives to that, but there's also, again, we're back to data integrity. We have to make sure we fill those things out appropriately. And especially since we've got 2 questions now about prior level of function, we've got to make sure that we are following the instructions specifically to what task they're referring to and how they're defining their prior level. As therapists, we know that prior level of function is an important piece of information, but we also know that this is discipline neutral data collection. So the response options are definitely not very nuanced necessarily, from independent can do all of it, needed some help, or dependent and couldn't do any of it. It seems, at times we're ending up with, well, they needed some help before, and they're probably going to need help when we're done. Is that a
Cindy, are you still there? Because I think we might have lost you.
No, I'm here.
Okay, you cut off real quick.
I'm here.
Okay, so Cindy, what is your when you fall asleep on 12/31/24 and you wake up on 1/1/25, what do you hope and pray does not happen in 25?
Oh, you're just poking me now. The issue is that because of the move of value-based purchasing away from the 1800s to go into the GGs, as I believe we've said on more than one of these in the past, we have to make sure that we're reporting accurately. What I'm afraid of is that suddenly no home health patients will be able to roll. They will not be able to do the oral hygiene. The ones that are going to factor into value-based purchasing cannot suddenly become, nobody can do this on admission, in an attempt to create the possibility of them improving. I think the key piece we have to understand that makes this so different with them projecting the discharge ability is this no longer makes this all about improvement. Because by using that calculation, they're trying to then say, okay, this patient, based on your assessment, appears to have the potential to improve. So they put it at a better level at discharge. Well, we get there, yay, we're successful. We exceed it, we don't get bonus points, okay? But that also means patients, being realistic, that are not going to get better, that are going to stay pretty much where they are. So think about it. You admit the patient to home health, they can roll, okay? They're perfectly independent and safe rolling around in their bed. Fine. I would anticipate that the goal for that one is for it to still be independent. Unless there's something absolutely weird going on, I don't think they're going to lose their ability to roll while they're a home health patient. Well, it starts out a 6, ends a 6. Yippee! That means we met the projection. So there's validation of patients. And even, let's be also fair, it is possible in this new math to project that the patient could decline. So it's not so much about, let's make sure the initial scores are as low as possible so we create maximum ability. I'm afraid that because they've been sitting on our GG data for years, if it looks significantly different in 2025, I think we're just going to get another round of the behavioral adjustment conversation.
Yeah, and guys, you want to be careful because this is all part of the Impact Act that occurred. It's legislation that they're trying to develop this document that moves with the patient from the hospital to potentially inpatient rehab to potentially skilled nursing to us. So if we receive that patient from skilled nursing and then we downgrade their ability, which is possible because they're moving into a non-regulated environment, we need to be really clear why it's different than what we saw at skilled nursing. And maybe they don't have handrails, maybe they don't have an adjustable bed, maybe there's a lot of different reasons why that could be scored different. Maybe they inappropriately scored it on discharge from the facility to make them look better. All of those types of things need to be factored in when you're scoring this. So let's all get together, band together, and give Cindy a wonderful New Year's gift of Scoring it accurately and not all of a sudden tanking all of their GG scores to make it look like they need more improvement. So we're all together.
Before we leave that though, Sherry, before people think, oh, she's just negative and she's being cynical, the industry already did that. We did that when the eating question got added to the discussion of payment related issues, because prior to that, and I've spent 2 decades of my life looking at people's OASIS documents, many patients were scoring as independent because that question is putting the food in your mouth once it's in front of you. It has nothing to do with meal preparation. It has nothing to do with carrying food to the table. And so fall risk really isn't an issue unless someone's going to fall out of the chair, which is a very significant problem. But people were feeding themselves, and all of a sudden, well, we're going to use this for, payment related, and nobody could feed themselves anymore. Even with our outsourced service team, our OASIS reviewers will say, we've got agencies that nobody can feed themselves without being supervised. It's like, wait a minute, hold up, what's going on? And I think some of it is, that kind of a track record. CMS is aware of that as well. So I have a feeling they're going to be looking for those type of changes in 2025.
So yeah, we try and provide guardrails for folks that partner with us. So we're trying to provide those same guardrails for you all that are on this Q&A, because it's about the accuracy. It's about, the good narration, if you will, in writing about what happened to that patient before they got to you from the prior facility. It's about taking all that into consideration and really being diligent about putting those nuances that are different between the settings that can cause someone to be downgraded, versus just saying, well, Cindy said don't downgrade them. That's not what we're saying. We're saying do it accurately and make sure if it is a downgrade, you document it appropriately. So Cindy, are we ready to go to the next one?
Yep.
Okay. OASIS instructions state to answer the CAM items after completing the BIMS. If you cannot complete the BIMS for some reason, discharge without a visit, can you therefore not complete the CAM?
Okay. The statement it talks about doing the CAM after you do the BIMS is not a regulation. It is not connecting those two in an official capacity. Think of it this way. It's really a common sense suggestion, because the CAM goes in a slightly different direction, obviously, than the BIMS, but it does deal with inattention and those kinds of things. So if I administered the BIMS, yes, I need to ask those questions specifically and follow all the parameters of that test. But if my patient is struggling there, it's already going to give me some food for thought when I go to answer the CAM. So I believe that that's just there as a, hey, it makes sense, do this after the one because they're kind of got some overlap, but that's not making it conjoined. It doesn't mean that if I couldn't do the BIMS, then I can't answer the CAM. It doesn't go that direction. But the example provided, Sherry, I gotta say something. Maybe it just should go to our unfiltered instead, but this whole discharge without a visit thing. I understand that it can happen, but it seems, and I could be completely wrong, but in the interactions we've been having lately, the questions I've been getting, the discussions I've been having, there seems to be a lot more of this. What am I supposed to do when we have this happen? And it's happening with regularity. I think there's different things. Yes, CMS does give us some guidance about what to do in that situation. And it hasn't varied in years in terms of then you have to back up to the last visit that was done by somebody who can complete the OASIS. And that individual is the one who takes over completing that document. And we know that that's frustrating, especially when it turns out to be you, because you're like, wait a minute, I know I did that visit, but I wasn't doing an OASIS. So I didn't ask these, I didn't do a BIMS, I didn't do all these other stuff, I didn't do it. So what am I supposed to do? Well, we do the best we can following the information from CMS, but their intent was that is supposed to be a very rare occurrence. It doesn't appear to be so rare now. And I think what we have to do organizationally is say, okay, realistically, are we tracking this? How often is this occurring? And is this really, what's the reason for it? Because to me, if I'm the one tasked to do the discharge and I have called this patient and they're, you really don't have to come, They don't understand what's involved on a discharge visit, that it is equally as important as the start of care because it's the final decision. It is the final once over where I am saying, I am confident that this person no longer needs any of our home care services. That I have done a full assessment here and I'm saying where they are now, there is nothing more for any of our disciplines to teach, train, do, modify, nothing. We have done everything that we can for this individual. They don't understand that. And I think what's happening, particularly with some of the staffing challenges, is the patient is kind of I really don't want to do this. I don't think I need another one. And we're just going, okay. Okay, because then we don't have to send somebody to the house. Okay, because then I don't have to go deal with this right now. Okay, I can just go do another visit and not do this. That's not how this is supposed to work. So I think we have to look at it and say, are we explaining to this person why this final visit is so important? Why it's valuable, that we can answer any additional questions, make sure that everything got taken care of, make sure nothing got left, out of the discussion. I think we would see more patients, if they understood it, agree to it. Because it just bothers me, Sherry, the number I'm seeing of, well, what do we do with this? Or my EMR isn't letting me do that, or we have it named this. And it's like, how many of these are happening? It really is meant to be a rare occurrence. And yeah, it screws up your OASIS data for that particular patient because it wasn't actually done. And it can't just be done by somebody in the office. It has to involve the last clinician of a discipline, that person who was there. And yes, I know there's that 1 in a million time we did this, we found this, that person quit, they don't work for our agency anymore. Now what do? That really should be rare. But I think we need to think about, track how often this is happening and think about scripting that conversation better. Now, if the patient obviously is absolutely not, there's no way you're coming, get away from me. I'm not saying we go over there, kick the door in and say, I got to do your discharge. But I think it's getting a little fuzzy and a little too easy to just say, oh, yeah, okay, fine, we won't. But it's going to cause problems on the data side.
And Cindy, I think you probably know what I'm going to say here. The issue that I have with that question is the word visit. And I say that very clearly because we are allowed to do telehealth visits in home health. We are 100% allowed. Are they paid for? No. So discharge without an encounter might be the appropriate thing to say. And I don't think there's any reason that we don't have an encounter for the discharge. Now, it may not allow you, and I know I'm opening a can of worms, it may not allow you to perform the BIMS because you're not in person with that patient, but it should allow you to answer most of the discharge questions, and it provides you with an end to that session or to that period of care. And Cindy, what do you think about that? What do you think about using an encounter, a telehealth visit with the appropriate G codes to wrap up that case versus just saying, well, they don't want me to come back out, I'm done?
Well, I think I just want to clarify because you never have a shortage of innovative ideas or challenging the boundaries, and it tends to make some people nervous. I just want to be very clear. You cannot telehealth in OASIS, okay? You can't patch it over the phone and not be able to see them. And you could argue, yes, I could possibly ask them the BIMS, and that's not what you're suggesting.
No.
I think the fact that it is, I'm supposed to come out today and do your discharge. I don't want you to come. Okay, the end. There are problems with that in terms of, do you have a conversation then about their medication? It may be possible with kind of a checklist of what am I going to go over with this individual, that you may find out that there's a very good reason for someone to go back and lay eyes on them.
Yep.
And that's where, again, I get nervous about well, he said he doesn't want me to come back anymore, so we're done. Somebody fill this out. It's like, but are you sure? To stress again, that discharge visit is just as important as that start or resumption of care. That last person through the door is the one making the final decision that there is nothing else for us to do for this patient, that we are done. So I'm not even going out there and just discharging my discipline. I'm making sure that they don't, as a PT, that they don't need nursing to come back in. They don't need OT. They don't need this, that all of that has been vetted. And I think sometimes, especially I even see it, Sherry, when OT was not more involved in the admission process, I would come to an agency to do OASIS education, and it would be RNs and PTs.
Mm-hmm.
I'd say, where's the OTs? Well, they don't admit. Do they do discharges? Well, yeah. Well, anybody touching a discharge has to have the same kind of training. That's not a blow off visit. So I think your idea about, at a minimum, what is that final conversation to make sure everything's been covered is a great idea.
I think it's a great idea, and I want to encourage you that if you do decide to go to an encounter model in that situation, that you write the policy, the procedures, create a checklist like Cindy just said, but also make sure that you bill those G codes for telehealth so that they know you're doing telehealth and that it's something that's valuable in the care of the patient. So that maybe sometime in the future, we can all, I have a dream it and get us to a payment for the telehealth and for the encounters outside and the things that clinicians do that are extremely valuable outside of physically going to a patient's home. So I think that the time has come that we access some of those other types of innovative tools that we have to do this, to make sure that we're wrapping that up. And I like your idea, Cindy, as a former agency owner, I like your idea of going over what has happened to see if there's anything else that patient may need, because I don't know about you, but referrals were always a huge thing in the agency that I owned. And so keeping patients that have a need is probably important to many of your agencies as well.
The one final thought I would add to that, Sherry, because it popped in my head when you said we're talking, is how many of us have been tasked with somebody's agency discharge that we never even saw.
Yep.
And so if I'm taking their word for it over the phone with no conversation, I know nothing about them. And again, ideally, you really don't want to be having the discharge done by somebody who's never seen the patient before, but we know it happens. So definitely, what is that final conversation? Because I have no context other than they said that they don't want us to see them anymore. That's it.
Yep. Exactly. So take an opportunity. That's a nice QA thing to wrap it up as well. So question number 8, and before I go on to question number 8, we're past halfway. So I want to encourage you, if you have any questions that pop into your head while we're talking, please put them in the chat box. And I'm going to go ahead and switch our slide to show you about our maintenance series. That encounter, that discharge encounter, is a great thing to do for maintenance. Possibly it's someone that would benefit from a maintenance plan of care going forward, and we have the training for that. Cindy Kraft and Dee Cornetti have written 2 books on maintenance, and we've been teaching on maintenance since 2013. And it is super important that you know how to do it, because you may get an additional documentation request on your maintenance because it's a new service that you're providing. But if you do it appropriately, it should not result in a denial. So it's a necessary thing. It's something, it's a benefit that is out there. So please consider looking into maintenance care for your clinician or for your patients that you're currently serving. So you ready for question number 8, Sin?
Yep.
Okay, another OT question. Yay! Okay, suppose an OT is performing a start of care admission followed by a PT assessment the next day. Is the PT assessment alone enough to determine home health eligibility, or the OT to continue services be permitted to bill? Case example, PT completed their assessment after OT did the start of care assessment. PT decides the patient does not require further PT services, but would benefit from continuing OT services to address patient needs. Does this meet regulatory requirements to continue as well as to submit for billing purposes, or must the PT demonstrate a need beyond their initial assessment in conjunction with the OT in order for the home health eligibility requirement to be met?
First of all, now you got to inhale, because that was a long question. But I like when people submit the longer question and give us context, because without context, sometimes it's hard to figure out what the question really is or how to best answer it. But there's a couple of things embedded in that particular question. From a technical standpoint, the issue is, can a single therapy visit qualify a patient for home care? And technically, a single PT visit absolutely can do that. Where there's been confusion and sometimes misapplication of the rules is nursing cannot do that. Nursing has to go more than once in order to be considered having met that criteria. Therapy does not have that same issue, which means that even if I went out and I was tasked with an admission, if I completed that assessment and at the end of all of that decided that this person really didn't need continued services, I provided skilled care on the visit, I did stuff, whatever. Can I actually get the LUPA payment for that visit from just one PT visit? Yes, we can. So technically that example, OT went and did the start of care, PT goes the following day. The documentation would need to speak to the qualifying criteria in terms of the ongoing skilled need for OT, that the patient is in fact homebound, under care of the physician. All of those things need to be met. I have a secondary piece to that though, because having read a lot of therapy documentation, typically when I see this, either as in the example, went out and did an evaluation only, I've seen it when nursing does the admit and it's the eval only coming from any of the therapies. Overwhelmingly, that evaluation documentation indicates that their patient was taught something, suggested something, recommended something, given a home exercise program, given activities to do, suggested pieces of equipment they could consider, and then we don't go back. That has never made any sense to me in terms of if I'm going to be recommending things or giving you things to do, why would I not come back to determine if what I did was effective? Was it in their best interest? Did it do what I intended it to do? So I've always looked at it this way, Sherry. If I've done a thorough evaluation and I've reached the conclusion that there is absolutely nothing for me to teach, train, or recommend, okay, eval only. If the patient is, refusing to let me come back, okay, I think they need more PT, but the patient has said absolutely not. I'm going to document that I would have recommended more, but I'm doing an eval only because the patient refused. But if I'm doing stuff and suggesting stuff, I believe there's an obligation to go a second time. And it doesn't have to be 2 days later. It could be a week later. It could be 2 weeks later. But this idea that I'm handing stuff out and running away is really concerning to me. And we didn't plan it this way, but it does go well with the slide you chose to have up right now. Because I think a lot of times when I see that eval only, and here's the assessment and here's the recommendations, it says, limit no rehab potential. Okay, hold up. So what you're saying is the patient is at an optimal level of function, not necessarily ideal, but for them, it's about as good as can be expected. And I felt the need to give you something to do. Then am I really talking about a patient that's a maintenance patient, where I don't reasonably believe that I'm going to get them any better than they are? And they may be in pretty darn good shape, but why did I give them an exercise program? Why did I suggest equipment? Because on some level, I was concerned that they may decline if they don't keep up an activity level, if they don't get these certain things in there. And that is in fact maintenance therapy. And maintenance therapy is explicit in the regulation about our obligation to determine the effectiveness of this program, which means you got to go more than once to figure out, did what you do actually work? So that's way longer winded than the question. But I think there's the technical, yes, it can be a single visit, but I've read far too many of them that are teaching and training and suggesting and doing, and then don't go back. I think that there's risks to the patient potentially. And how do you know what you suggested was effective if you don't go back and check them out again?
And Cindy, I want to tell you that that was a great explanation, but we do have a question that came in. I want everybody to know that we might not get to all of our submitted questions in our time frame today. However, they do roll over to the next session. And if you have any further questions, I'm going to go ahead and switch the slide. You can reach out to us directly after this live session to get your questions answered. I apologize if we didn't make it to all of them, but these are some great questions, guys. So thank you so much for turning them in. The question that just came in was, the person is confused with the first statement as they don't practice this. If the OT does the start of care admit and the PT does the assessment the next day, who is doing the OASIS and what is the start of care date for M90 in N0090? I thought we said OT can't admit, #confused.
Okay, So it's important to go back and look at the regulations in terms of the fact that we have what's called an initial assessment and we have and a comprehensive assessment. So the initial visit to get them started on care and the comprehensive assessment is what includes the OASIS and all that other stuff. Overwhelmingly, the industry has combined that into one thing. And this is where I think what we're seeing is a variation causing the confusion is that there are situations where agencies have chosen that PT cannot do the admission. And that if they get an order and it is for PT and not nursing, they're going to have a nurse go and do that comprehensive assessment. They are not going to be able to bill for it, so they eat the cost. I don't understand why people have done that in the past and continue to do it, but some do. In that situation, the nurse is not a billable visit. The nurse isn't technically even ordered. And as we said before, going once does not qualify this patient for home care. If I'm electing to do it that way, then I have to send PT on the same day, or else the start of care date and all that other stuff gets messed up. So in that situation, when a non-billable nursing visit is being done to admit them, the PT has to go on the exact same day to make that work from a coverage criteria, regulatory thing, the whole billing, the whole 9 yards. This situation is not the same because OT and PT have both been ordered. OT cannot admit a patient to stand alone. OT cannot go in there and be the only service, but they can be in there with other services. And we've seen that historically, when we've had, let's say it's PT and OT ordered as this example, PT's been the one doing the admission because yes, it's the qualifying service. But we saw with the waivers that there was the ability to be a bit more flexible there and that OT could go out and initiate it with the understanding that the other service coming in is going to deal with the qualifying part and speak to those qualifying criteria. The qualifying criteria is not the OASIS assessment. Okay, the qualifying criteria, if we go look in the conditions of participation, are talking about the patient is under the care of a physician, that they are in fact homebound. We have the face-to-face requirement, all of those technicalities that say you meet the criteria for Medicare to be the payer. So I hope that helped because I think that historically it's got to be the same day thing has been connected to nursing, which doesn't apply here. But that PT visit the following day is dealing with the qualifying criteria element. So the start of care date would be when OT went. And if they got everything they needed to know about that patient done on that day, then that would match in the M90 date. If they did, in fact, collaborate with the PT after their evaluation and then decide, okay, this is what I'm going to answer certain questions now as the OT based on my conversation with PT, then that would change the 90-day.
And so if we have another clarification, so nursing can't do a start of care only visit if no other visits are ordered, correct?
Can do it? Yeah, they can go to the home and do it. Can you bill for it? No. Medicare will not pay for a one-time only nursing visit.
Okay, so that's
Other payers might. So this is where you got to look at it and say, that's a Medicare rule. Other payers, because I always look at it this way. You're saying, okay, wait a minute. So they won't pay for one-time nursing visit. The nurse needs to go at least twice. Yeah, okay. So go to the insurance side. Do you want them to go at least twice? No. Can you get it done in one? Because then I only have to pay you for one. So other payers can view this differently, but Medicare says just one single nursing visit is they won't pay for it. So that's why when it gets rigged up with to work around a PT admit, it ends up non-billable.
So what I want folks to do, if you have any further questions on this, because it is a hard and fast, right? And hard and fast sometimes are hard to accept if you've been practicing another way. I want you to look at Cindy's email address, craft@valuebeyondthevisit.com. Reach out to her directly and start that dialogue. And we are real happy to talk to folks and get them the information that they need. But I wanted to let everyone know that we're on the last question. And I want, if we can, I see I have a wrong graphic on this final slide. Don't you love that, Cindy? our next session is not today at 1 o'clock. Our next session is actually November 21st from 1 to 2. And for those of y'all worried about Thanksgiving, Thanksgiving is the 28th this year, which is really late, it feels like. But so we're a week before Thanksgiving. We'll have our probably next to the last one of the year, because we'll probably do something in December to get everyone prepared again for January and the changes that are upcoming. But I wanted to end on our favorite subject. Cindy, are you ready? Well, it might not be yours, but I know it's our firm's favorite subject, particularly our director of operations' favorite subject. Okay, it's a face-to-face question, ladies and gentlemen. Drum roll. Okay, we often service patients for a few episodes when we discover they have signed up for a Medicare Advantage plan or switched out of Medicare Advantage plan, resulting in a change of payer. This will require a new episode of care and therefore require a face-to-face. For a community referral, the provider that did the face-to-face encounter must certify home health services and sign the plan of care. Is this change of payer considered a community referral, therefore requiring a face-to-face encounter by the certifying provider, or can we use the face-to-face encounter that was done in the acute care facility by a hospital provider for the original start of care as long as it was done in the last 90 days, and the encounter is for the primary reason the patient continues to require home health? I did that in one.
You did that, but you're going to need to inhale because I am not a coder. So I am punting face-to-face back to you.
It has to do with the plan of care, right? It has to do with what you're going to be doing for that patient moving forward. A change of insurance rarely changes that. So as long as you're within those time parameters, the 90 days prior, 30 days after, you can continue to use the same face-to-face that you used for the initial encounter. Now, if they keep on the payer for research or resumptions of care and those types of things, there is not a requirement for continuing face-to-face in that situation. So as a recommendation, I would suggest for those long-term patients that you have maybe for B12, for Foley changes, the ones that can go on for 6, 8, 10, maybe even over a year, I would recommend that you set a policy that every so often you attain a new face-to-face, because there could be significant changes that occur that you're not aware of, and getting one from their primary care physician is super important. But for these payer changes, unless it falls outside of that time frame, I don't believe there's a face-to-face requirement there. Do you have anything you'd like to add?
No, I don't. So if we still have 3 more minutes, can I put one question back in?
Sure.
The one about the wheelchair.
Okay, I'm going back to the wheelchair one. Okay, now that was the fake last question.
Well, you were able to answer that one so concisely. We can get one more in because this one is very concise as well.
Okay, but before I forget to say something, please put positive vibes out that Cindy's husband can make it home today before the storm hits. We need all of our positive vibe warriors to put that out to the universe that his flight actually does take off from Illinois at 3:30 and land in Atlanta when?
Well, it's already got a delay, so hopefully it's 7.
Okay,
before
so
things get worse.
Let's put it out there that Cindy doesn't have to go through this storm in the dark alone. So with her cats, Cindy, I hate to say that. That sounds terrible, but it just so happens timing with your husband's work. So put it out there. I'm recruiting all my positive vibe folks to get that to happen so he can make it home. Cindy's like, why are you putting my information on blast? Okay, for the GG wheelchair mobility question, if the patient uses a wheelchair all the time at the time of discharge from the hospital because it is their policy that they have to be wheeled out to the car, do we capture that in GG 0170Q? Does the patient use wheelchair or scooter?
Well, the guidance does talk about that we are to answer those if they use a wheelchair or scooter in any capacity. The example, though, is a hospital policy that wheels you to your car. So that is not a patient need to use that for any sort of transportation. That's being dictated by the facility. So I would say no. If that was the one and only time that they were using it, that would not meet the criteria of them using it for some sort of transportation. The issue was meant when they say in any reason is for those situations where the patient is, let's say, completely ambulatory in the home, but when they have to do long distances for a doctor's appointment, they have a wheelchair and they use it under those circumstances, then it would be yes. but dictated by hospital policy, regardless of their ability, I would say no.
I fixed my problem on the screen. Okay, so I want to thank everyone for joining us today for our Q&A, and we really enjoy the questions that are submitted. And this time you guys did so great. We didn't even get through all of them. So if you have any questions, please reach out to us. We love the interaction. We love to hear what's happening on the boots on the ground. And those of you that are in the path of this storm, please take heed and be safe. And I hope your patients are safe and everything else. And we'll see you again on Thursday, November 21st. From 1 to 2 p.m. Again, thank you so much, and please be safe out there.